Hi, welcome back to PsychoBible. I'm Andrew Rodriguez. We've been exploring the different myths and misunderstandings about conversion therapy. So far, we've gone over the term itself, the different bans and attempts to censor people who have left homosexuality and those who practice counseling to help people with unwanted same-sex attraction. And we've gone over the coercion myth. So now this leads us to probably the biggest myth, the one that is the most powerful and that most people tend to believe. And so even people who may not be for homosexuality will be against therapy for homosexuality because they've fallen for this particular myth. And this is the harm myth, the myth that all attempts at changing orientation are innately harmful. So when they say that therapists are harming people by offering counseling for this issue, there are a few particular accusations that are coming up. And this is what really most people think of when they hear this harm accusation, is one, that we are using methods that are harmful in themselves, such as torture, basically, like we're back in the 1500s, that we are like using electroshock therapy, that we're hooking up electrodes to someone's genitals and then making them watch gay pornography and then shocking them if they get aroused so that they can associate something negative with it, or ice baths, or throwing ice water on them, or poking them with needles. Like all these barbaric forms of treatment is what they're accusing therapists of doing. Then they move on to shame, that, well, you use shaming techniques. And so they'll usually use a lot of anecdotal reports of people seeing a counselor and the person berating them, belittling them, maybe being confrontational with them about their homosexual behavior or even the attractions, which may be true. There may be some truth in some of these claims based off some anecdotal evidence. Then, of course, there's the claim that it's because just the existence of therapy for this that causes stigma in society, and enough stigma that it drives people with same-sex attraction to commit suicide. So this accusation of torture comes from the idea that we're all using aversive techniques in our counseling. Now, what are aversive techniques? Those are techniques where you're using some sort of pain and pairing it up with experience of same-sex attraction or arousal, so that the next time you have the attraction or find yourself attracted or aroused by that homosexual stimuli, you then associate with a painful feeling. And enough of that happens, you will then have an aversion to the homosexual stimuli. So to really address this, we need to take a brief look at the history of modern psychology. Now, modern psychology really began at the turn of the 20th century with Sigmund Freud and his development of psychoanalysis, which believed that it was from early childhood experiences that we developed most of our mental disorders and our personality. And psychoanalysis was the main and pretty much only form of therapy that was used for decades, until it began to fall out of favor as we were looking for more scientific approaches, stuff that we could measure more. And so that helped bring the rise of behavioral psychology. And behavioral psychology really hit its peak in the 60s. And psychologist Joseph Wolpe began introducing behavioral techniques, including aversive techniques, in counseling people of unwanted same-sex attraction or homosexual behaviors. So yes, he would use aversive techniques, but not just aversive techniques. Also, the one approach that he is known for creating, systematic desensitization. In particular, he would use that to sort of help the client combat heterophobia, or a fear of the opposite sex, or heterosexual interactions. Positive reconditioning, which may involve things like inducing arousal through homosexual stimuli, but then before reaching the climax, switching to heterosexual stimuli. And social skills training, such as helping the client to better relate to the same sex, better relate to the opposite sex in a more heterosexual manner, assertiveness training. So it would involve more than just aversive techniques, more than just, inducing pain at the homosexual thoughts. But there's more approaches in that repertoire. So, and really, if we look at this whole thing in context, aversive techniques were pretty much used commonly for unwanted impulses. So it wasn't exclusive to homosexual behavior and attractions. Now then, in 1973, homosexuality was removed from the DSM, so it became something people came to treatment less and less for, and also behavioral therapy began to fall out of favor and wasn't in vogue anymore. So the different waves came in psychology. However, the psychoanalysts were still using their approach to treat unwanted same-sex attraction if it was ego-dystonic. And then we had a bit of a psychoanalytic resurgence through clinicians like Charles Socarides, Joseph Nicolosi, and they were really inspired or influenced by Elizabeth Moberly's work that viewed homosexuality as a shame-based impulse or mindset, and so the approach was to resolve the underlying emotional issues using psychoanalysis and the therapeutic relationship. So aversive techniques would not have been used by those clinicians at all because it wasn't even part of psychoanalytic training or psychodynamic therapies at all. And it was these clinicians that went on to form NARTH, the National Association for the Research and Therapy of Homosexuality, in 1991. So most people who ended up doing reparative therapy, which was the approach that Nicolosi developed, were coming from more of a psychodynamic approach, not a behavioral therapy approach. So aversive techniques definitely would not have been used. So we can safely say that therapists who were actually trained in professional therapies and how to help people with unwanted same-sex attraction haven't been using aversive techniques since the 70s. So there's really not much truth at all when someone says that modern therapists are using torture or aversive techniques. Now really, if anything, it's the non-professional therapists, if they are out there, the conversion therapy camps that might be using these torture techniques. But you're not going to see that in a professional therapy setting. I don't know any pastoral counselors or any of the ministries that are part of Restored Hope Network that would use these techniques. And really, who has the equipment? Electroconvulsive therapy or some of the things that they're talking about would require a lot of specialized equipment that I don't know anyone who has access to. So then we had, in 2009, the APA Task Force Report on Sexual Orientation. And they had a whole section in the report investigating the question of harm from sexual orientation change efforts. And after looking over as much of the research that fit their criteria, they found that most early studies of aversive techniques did not include measures of harm. So even though conventional wisdom would tell us that aversive techniques would be harmful, pretty much in and of themselves, there actually wasn't much research to back up that claim. Nevertheless, I would still say it's common sense that to use those sort of techniques is not going to be helpful. And even if it might produce some change in the attractions or behavior, I suspect that that change is only going to be very fleeting and temporary and won't be long-lasting because you're not really dealing with the root emotional issues. You're just treating behavior and behavior modification. They found one experiment. Now, an experiment means that there's a variable that's being manipulated. So not all studies are experiments. So they found just one experiment from the early years, and it did show some depression and loss of sexual feeling. And then there are some other small non-experiments, but just in general, barely any research that can back up the claim of harm. And that's in the older studies where they actually used aversive techniques. And then when it comes to modern forms of sexual orientation change efforts or change-allowing therapies or safety, there are barely any recent studies that they could use to measure this. However, in the APA Task Force report, it does mention a couple studies that has participants mentioning some reports of perceived harm. And the main study, this is the big one, where they get their idea that therapy for same-sex attraction causes harm, is a study by Shidlo and Schroeder from 2002, titled Changing Sexual Orientation, a Consumer's Report. This is the main study used to justify the sexual orientation change effort bans in different states. It was a study sponsored by the NLGHA, the National Lesbian and Gay Health Association. So this is a big study, and this APA task force report is what is often cited to justify the bans and censorship out there. You would think, wow, this must be a smoking gun, must have all sorts of proof. There's some problems with this study, though, that most people aren't even aware of, because, to be honest, most people don't have access to the research. They're just trusting the APA to be honest. Or if people are being dishonest, the APA actually has a responsibility to correct people if they're misrepresenting the research. You'll see here that's not always the case, though. First, with the Shidlo and Schroeder study, you see a very biased recruitment strategy. Initially, they advertised almost exclusively through gay bars, gay magazines, and other outlets, and they used an advertisement that said, "Have you been harmed by homophobic therapies? Help us document the harm." So right there, you're seeing their bias in what it is they're researching, and they're eliciting people who've tried some sort of counseling and walked away disgruntled and dissatisfied and felt like they were harmed in some way. They later got some criticism for their recruitment strategy, so they broadened it and they tried to make it sound more objective. But right there, they revealed their cards. They showed where they're coming from. So I have a hard time accepting their conclusions or the way they write out the report as being objective. Also, this was a retrospective, subjective interview. So this was not an actual experiment where you take people before they start the counseling for same-sex attraction and you measure their mental health status and how much they're depressed, and then they do the therapy, and then afterwards you measure those same things again. It's not an experiment. Instead, it's a retrospective. You ask them, have you already gone through this therapy? And then you ask them to recall how they felt before the therapy and how they felt afterwards to see if things changed or if things got worse. And the average number of years that had passed between the time the clients were, or these participants were in some form of help, and when they got interviewed was 12 years. That's the average, so give or take. There might have been more time that passed. On top of this, a third of the people that these clients saw weren't even licensed mental health practitioners. So, pretty much, this Shidlo and Schroeder study says almost nothing about the risk of harm from professional ethical therapy. It does tell you that there's a chance of harm from maybe some ministry approaches or pastors who aren't really professionally trained and are ill-equipped to do counseling in this area, or self-help groups. Like, maybe there's a risk of harm there, but they didn't match the types of harm reported with the type of treatment they did or type of help they received. So we don't know if the greater types of harm or perceived harm were from the helpers who weren't professionally trained, or were they from those who were professionally trained, or was it mixed? We don't know. And what are these types of harm? They mentioned depression and suicidal ideation, but if you look at all the research where they report perceived harm, it's very broad and sometimes vague. The reported negative social and emotional consequences include self-reports of anger, anxiety, confusion, depression, grief, guilt, hopelessness, deteriorated relationships with family, loss of social support, loss of faith, poor self-image, social isolation, intimacy difficulties, intrusive imagery, suicidal ideation, self-hatred, and sexual dysfunction. Once again, that's very broad, and we don't always know how much of which types, and in general, and then also how much of which types were associated with what type of counseling or help the person received. And they didn't corroborate to see, okay, are there ways for us to really find out were these people actually suicidal? They don't investigate that far. You're taking the clients or these participants at their word. Also, you did find, if you look at the data more, you see that suicidality was pre-existent. So these people didn't become suicidal just after therapy. They were already suicidal before therapy. And in many of the cases, the therapy helped curb the suicidality and help save them. But what gets reported is that, well, it was harmful. Or at least they reported harm. So, even though most people will say the APA, the American Psychological Association, condemns reparative therapy, condemns sexual orientation change efforts, condemns change-allowing therapies, ultimately in their report, at the end of the section on harm, they admit there's limited rigorous early studies and no rigorous recent studies. Don't believe me? I'll quote it to you from page 42. Regarding recent studies, although the recent studies do not provide valid causal evidence of the efficacy of SOCE or of its harm, some recent studies document that there are people who perceive that they have been harmed through SOCE. And then in their summary section, we conclude that there is a dearth of scientifically sound research on the safety of SOCE. A dearth. Early and recent research studies provide no clear indication of the prevalence of harmful outcomes among people who have undergone efforts to change their sexual orientation or the frequency of occurrence of harm, because no study to date of adequate scientific rigor has been explicitly designed to do so. Thus, we cannot conclude how likely it is that harm will occur from SOCE. Now they go on. However, studies from both periods indicate that attempts to change sexual orientation may cause or exacerbate distress and poor mental health in some individuals, including depression and suicidal thoughts. Sure. But they finish. The lack of rigorous research on the safety of SOCE represents a serious concern, as do studies that report perceptions of harm. You know what? You're right. It is a serious concern that people would continue to say that this therapy is harmful without the actual scientific backing. You know what you should do instead? Promote more research. Appeal to more research being done, and sponsor and fund more research if you really want to be definitive about this subject. Now, that said, they also admit that reports of harm were countered by reports of benefit. Things like feelings of relief and happiness, improved relationships, spiritual growth, improved mental health status. And all of this was even if the same-sex attraction didn't change. So even though you might find some evidence that, well, maybe this isn't as effective, they still found that it doesn't mean it was harmful, that even people who didn't find the level of change in their sexual attractions, they still walked away from the therapy with improved self-worth, decreased depression, better social functioning. So is it really a loss? And it doesn't seem like it was an actual harm. So the truth? Professional therapy hasn't used aversive techniques since the early 80s at the latest, and in reparative therapy, or now called reintegrative therapy, same-sex attraction is viewed as a shame-based or trauma reaction. Therefore, the actual aim is to heal that source of trauma, that source of shame, not to add more shame. None of the therapists I know use shaming techniques, such as blaming the client for their same-sex attraction, or trying to guilt them into trying to change, or staying the course in therapy. No, we are entirely client-directed. We're working with the client on their goals that they bring to the table. We're not forcing anything on them. What we do see are multiple reports showing improved well-being outcomes. Marked improvement in depression, suicidality, self-esteem, assertiveness, social functioning, spiritual growth, and sobriety, since a lot of clients with same-sex attraction are also dealing with drug and alcohol issues. We see these reports documented in multiple studies, such as one from Lee Beckstead in 2001. Keep in mind, Lee Beckstead is a gay activist psychologist who was on the APA task force. So even in his study where he found that SOCE wasn't so beneficial to the clients, it did still improve their mental health. Robert Spitzer, in his study of people who claimed to have been helped by different forms of SOCE, also found that their mental health status increased. Carton and Wade found evidence of this in their 2010 report. Jones and Yarhouse, in their longitudinal study of participants from different Exodus ministries, not only do they report degrees of change in their attractions, but also increased mental health status. And in a recent study by Santero, Whitehead, and Ballesteros in 2018, they found this. They actually were intentional in measuring their mental health status before and after treatment, and they made similar claims. So, to prove if SOCE or safety or change-allowing therapies are harmful in and of themselves, a few criteria must be met. You need to measure the mental health status before and after treatment using the same standardized methods. Reports of harm must exceed the benefits of the therapy. The negatives must exceed those of the negatives from different control groups. Maybe a control group that is doing gay affirmative therapy instead, or a control group that is not doing any therapy, or control groups of people doing therapy for other mental health issues. Reality check. There is a risk of harm and lack of benefit in all therapy. There's always that chance you're not going to be satisfied with therapy and if it was going to benefit you. And therapy regret is not harm. If you have a client who comes in, they want to work on the same-sex attraction, and they want to explore their heterosexual potential, but through the course of counseling, they decide, no, you know what, I'm going to embrace a homosexual identity and explore a homosexual behavior and relationships. So therefore, they now regret their time spent trying to work through the issue instead. That doesn't mean they were harmed. Might not be that they benefited in the way that they had hoped, but that is not the same thing as being harmed by therapy. And that's often what I hear from some of these anecdotal evidence of harm. Another reality check. Clients with same-sex attraction oftentimes have pre-existing mental health issues. Now, we are often told that the reason why they have these issues is because of stigma in society. But an alternate explanation would be a shared root cause. So therapists in my field would say the same cause of the depression and anxiety and the drug and alcohol abuse and all the other trauma reactions would be the same cause of the same-sex attraction itself. Of course, this makes sense if you come to the conclusion that same-sex attraction is a disordered desire. But if you're determined to accept the idea and promote the idea that homosexuality is a normal variant of human sexuality, then of course that's going to offend you. And you may deny evidence that shows that same-sex attraction may be caused by certain developmental experiences or traumas. And another reality check. Torture and shaming clients is already banned. There are already laws in the books against hurting clients in such ways. So these bans against SOCE, based on the idea of it being harmful because of aversive techniques or shaming approaches, are superfluous at best. They're really a red herring, because it's not about them potentially causing harm. It's about, we don't like that this type of therapy is even being offered. It's a conflict of values, and the opposition to therapy wants to make sure there's only one value being promoted, and that is LGBT inclusion, celebration, and acceptance. I tell you what is harmful, and that is violating a client's right to self-determination. That's banning therapy for people who are survivors of trauma and abuse, particularly sexual abuse, who may be able to trace the origins of their same-sex attraction to the time when the abuse occurred, and now say, nope, you're not allowed to get therapy for that because it might change your orientation in some way. Another thing that's harmful is many of the aspects of homosexual behavior. It is well documented that the LGBT community is at greater risk of anxiety, depression, substance abuse, 4 times greater, suicide, 2.5 times greater, domestic violence, 6 times greater, and sexual compulsivity, over 6 times greater. Also, among gay Americans, HIV has been rising 8% annually since 2001. So I might consider it harmful to encourage people to embrace a sexual lifestyle that may increase their chances of illness and other harmful outcomes. But of course, we have to blame it all on stigma. But if you look at other countries that have been more gay-affirming than even the United States, particularly developed countries in Europe and the West, you'll see that the decreased stigma has not resulted in better mental health and drug and alcohol outcomes. In Denmark, 12 years after they legalized same-sex marriage, or they would call it a same-sex registry, suicide was 6 times more likely in gay partners and 2 times more likely for single gay men. In Australia, Netherlands, Switzerland, and the UK, you still see decreased mental health and social health, especially among bisexual men, who, you may not know, is the largest amount of people in the LGBT community. It's very rare for someone to be exclusively same-sex attracted. There's usually some degree of opposite-sex attraction, and that's the majority of people in the community. So they're the ones who most report negative mental health. So I would actually say a more compassionate approach would be to make sure people have options. If they want to take their chances and sometimes take a risk in embracing a homosexual behavior lifestyle, then they should have that option. I don't believe in anti-sodomy laws. That's their choice. But they should also have the choice to pursue therapy that will better suit their values and possibly save their lives in some cases. So to sum up, the accusation that professional therapy for unwanted same-sex attraction is innately harmful has no validity. Now, once you debunk that, the opponents will move on to the effectiveness myth. Well, it might not be harmful, but it's not benefiting them. So that's what we're going to address next. Okay, once again, if you haven't already subscribed or hit the like button or shared, please do so. These videos aren't going to get very popular on YouTube, so I really appreciate your help in spreading the word and increasing their ability to get out to people. I hope you can use this as well to share with your friends who may be spewing a lot of these myths. Okay, thank you so much. God bless.